Okay, I think that's everyone from the waiting room. We are actually going to go ahead and get started so we can hear all the presentations and have time for a discussion. Hi, everyone. I'm Erin Hager. I'm faculty in the Department of Population, Family, and Reproductive Health, and I have the honor of moderating this master's essay session today with three wonderful students. So the first student we're going to hear from is Madhumita Ramesh. And Mita has a Bachelor of Science degree in Human Development from University of California, San Diego. She's in the maternal, fetal, and perinatal health area of interest in our department. And her master's essay title is Risk Factors Associated with Custody Loss of Opioid-Exposed Newborns During Delivery Hospitalization. So Mita, you can go ahead and share your screen and get started whenever you're ready.
Okay, great. I hope everyone can see my screen. Good afternoon, all. My name is Madhumita Ramesh, and I will be presenting on the risk factors associated with custody loss at delivery among opioid-exposed newborns. In this presentation, I will go through the background and purpose of this research study, the methods, results, and the discussion of the findings. It's important to provide a brief overview of the opioid epidemic and its beginnings. In the 1990s, prescription opioid medications, such as hydrocodone and oxycodone, were widely prescribed to treat pain. However, prescription opioids had a high potential for misuse, and as a result, overdoses involving opioids increased at alarming rates well into the 2000s. In an effort to combat prescription medication misuse, there were restrictions on the ability to prescribe these medications, so they became more difficult to procure. At the same time, there were increases in the production of heroin, an illegal opioid, which became inexpensive and widely available. Finally, the third wave of the opioid epidemic was due to the rise in use of illicit fentanyl, which is a synthetic drug more potent than heroin and is often mixed into other illegal substances such as cocaine or counterfeit pills. And in 2016, fentanyl became the opioid most involved in opioid-related overdose deaths. As the rates of opioid use have generally been trending upward, it's important to identify its impact on pregnant people. Maternal opioid use disorder is opioid use during pregnancy. Physiologically, opioids affect men and women differently. So women tend to actually progress faster from first-time use into addiction. And as of 2017, the estimated national rate of maternal opioid use disorder was 8.2 per 1,000 deliveries. So besides having impacts on the health of the mother as well as the fetus, a major yet understudied consequence of maternal opioid use is custody loss at delivery, specifically. So substance use during pregnancy and the postpartum period is a well-studied risk factor for Child Protective Service involvement, as treatment providers and Child Protective Service agencies often link substance use with child maltreatment. So in 2020, 51% of children under the age of 1 who were removed from parental custody were removed due to parental substance use. Custody loss during delivery hospitalization is an understudied consequence of maternal opioid use disorder. So it can result in several adverse outcomes, including hopelessness and increased use as a coping mechanism, poor mental health, increased risk of overdose, trauma, and isolation. Pregnant people with substance use disorders are less likely to engage with the healthcare system and seek treatment due to possible legal consequences. Understanding the risk factors associated with custody loss is crucial to help increase treatment engagement during pregnancy and reduce the likelihood of custody loss during delivery hospitalization. So the purpose of this study was to identify the risk factors that are associated with custody loss at delivery among opioid-exposed newborns. Delivery hospitalization is defined as the time after birth and prior to the mother's discharge from the hospital. This was a retrospective cohort design analyzing opioid-exposed deliveries at Massachusetts General Hospital between 2016 and 2023. It's been well documented that the Northeast is disproportionately impacted by the opioid crisis. So it was the best approach for this study to use this particular database. From this database, sociodemographic, medical, and delivery hospitalization data were all analyzed. So the inclusion criteria for this study were infants live born to mothers with a diagnosed opioid use disorder at MGH between 2016 and 2023. And the original sample included 277 cases. However, cases were excluded due to participants having missing information for multiple variables, and when there was an extremely small number of cases for a given category of a variable. And these additional exclusions were necessary just to maintain the statistical power of the results. And so the final sample was 174 cases, and the data was analyzed using Stata B. There were 11 independent variables analyzed in this study, including race, ethnicity, insurance, marital status, participation in Hope Clinic, which is a clinic at Mass Gen that focuses on providing care to pregnant people with substance use disorders, as well as their infants, homelessness, cocaine use disorder, tobacco dependence, the number of psychiatric diagnoses, in utero exposures 1 month prior to delivery, pharmacotherapy at delivery, and whether the mother has previous living children. The dependent variable was custody loss at delivery, which was determined using discharge disposition. So, for example, if the child was documented as leaving home from the hospital with the mother or the biological parent, then it was determined that custody was not lost. However, if the child went home with a foster parent or an adoptive parent, then that would indicate that custody was lost during the delivery hospitalization period. In this sample, 75% of mothers retained custody and 25% lost custody during the delivery hospitalization. So to give a brief overview of the demographic characteristics of the total sample, 85% were non-Hispanic white, 85% were also on Medicare or Medicaid, 76% were single, 40% had a cocaine use disorder, 79% had tobacco dependence, 82% had 2 or more psychiatric diagnoses, 54% had a history of homelessness, and 19% used illicit substances, so either heroin or fentanyl, 1 month prior to delivery. A multivariable logistic regression in Stata was used to analyze these results. So from the adjusted odds ratios, we can see that the mothers with a cocaine use disorder, history of homelessness, and illicit substance use 1 month prior to delivery all had a higher odds of custody loss during delivery hospitalization. So none of these sociodemographic characteristics like race, ethnicity, insurance, or any of those demonstrated statistical significance. So it's important to note that the use of fentanyl or heroin only was also initially analyzed, but was determined to be a rare exposure, which is why it was excluded from the analysis. Finally, it's important to put these findings into the context of the existing literature. So cocaine use disorder can serve as a proxy for polysubstance use, which refers to the use of multiple substances simultaneously. So additional substances are often used to alleviate the negative withdrawal symptoms of opioids, which is why they're prevalent among those who use opioids. Cocaine use does have some important historical context. So back in the 1980s, cocaine use was the #1 predictor of custody loss among newborns in the context of the crack cocaine epidemic. And so this finding is consistent with the literature that cocaine use is often associated with child custody loss. Illicit use of fentanyl or heroin 1 month prior to delivery, in addition to prescribed medication for opioid use disorder, which is what MOUD stands for here, was also found to increase the risk of custody loss during delivery hospitalization. So MOUD alone could serve as a protective factor since it did not demonstrate any statistical significant increase in the risk of custody loss. However, as I mentioned before, it's important to note that this finding is strictly preliminary, as the sample for the group that used heroin or fentanyl only without prescribed opioids had to be excluded from the analysis. Lastly, the third variable that increased the risk of custody loss was homelessness. So the population of homeless females has grown considerably in recent years, with much of it related to substance use. And families struggling with homelessness are often investigated by Child Protective Services. So this finding is also consistent with the literature that homelessness does increase the risk of custody loss. The opioid epidemic in the United States has had severely detrimental impacts on the overall population, as well as for pregnant individuals. Custody loss during delivery hospitalization, as I mentioned before, is very understudied, but a very crucial adverse outcome of maternal opioid use. This study can strictly demonstrate preliminary findings for the factors that could increase the risk of custody loss during delivery hospitalization, as there were a number of limitations pertaining to the sample. So the sample was very small, with only 174 cases collected from a single site, which was MGH in Boston, which is in the northeast of the United States. Furthermore, the sample was racially homogeneous, with 85% of it being non-Hispanic white. The perinatal period is a very vulnerable time for any mother, but also for mothers who may be struggling with an opioid use disorder and navigating the legal and emotional complexities of custody loss during delivery hospitalization. Based on the results of this study and its limitations, future studies should replicate this methodology with a large multi-site sample to determine whether these risk factors are consistent and can be more generalizable to the overall population of the US. I would like to acknowledge my wonderful advisors, Dr. Allison Gemmel in the PFRH department, as well as Dr. Davida Schiff from MGH, as the study would not have been possible with their support, as well as the support of the PFRH department. Thank you very much for listening to my presentation.
Fantastic job, Mina. Your presentation was so clear and your findings were really interesting. We have about 5 minutes for questions and answers. So if you have a question for Mina, please just come off of mute and feel free to ask your question, or you can put it in the chat. I can start with a quick question. If you happen to look at multiple risk factors and whether how many individuals in your sample you were demonstrating homelessness and cocaine use and multiple things, and whether there was any sort of multiple risk factor aspect of this?
So for this study, we didn't do the analysis in that particular way, as it would be a little bit complex. But while I was doing the research, I would be able to see, go back and look at, okay, how many people had, multiple of these factors at the same time. But yeah, it wasn't analyzed in the logistic regression, but
yeah,
technically it'd be possible to see that.
Or being peripherally involved in a study years ago where it was hard because tobacco use was kind of ubiquitous, and there were some other issues with kind of multiple uses. No, it's really, really interesting. Are there any other questions for Amita? So when you move on to your next phase, are you going to stick with this topic area? Is this something you're particularly interested in?
Yeah, it is. Addiction medicine and this perinatal period is definitely my main research interest.
Oh, that's great. I'm glad you were able to do this for your master's then.
Yeah, me too.
No other questions? All right, we only have 3 speakers today, so we'll have a little bit of time at the end as well. So if you think of a question, we can loop back around after the final presentation. So wonderful job, Mina.
Thank you so much.
All right, so our next speaker is Jacqueline Nguyen, and Jacqueline's going to share her screen. Jacqueline has a Bachelor's of Science in Biological Sciences from the University of California, Santa Barbara. She's also in our maternal, fetal, and perinatal health area of interest. And the title of her master's essay is School-Based Mental Health Interventions, Recent Advancements and Best Practices. Go ahead, Jacqueline.
Sorry, I forgot to unmute. So thank you, Dr. Hager, for the introduction. And like she said, my name is Jacqueline Nguyen, and I'll be presenting my thesis entitled School-Based Mental Health Interventions, Recent Advancements and Best Practices. So to start us off, here's a brief overview of the mental health crisis among children and teens in the US. Nearly 20% of children and young people ages 3 to 17 have a mental, developmental, or behavioral disorder, with the most commonly diagnosed mental disorders in children being attention deficit hyperactivity disorder, anxiety, behavioral problems, and depression. So prior to the pandemic, 1 in 5 children had a mental disorder, but only about 20% of those children received care from a mental health provider. And in the decade before 2019, suicidal behaviors among high school students have increased by 44%, with about 16% having made a suicide plan within the prior year. So given this, this is a critical public health issue that needs to be addressed, which brings me to the purpose of my thesis, which was to review recent research and identify best practices in school-based mental health services and their implementation. So you may or may not be asking, why schools? Well, schools serve as an opportunistic setting which offer a more accessible, less stigmatizing environment than traditional community-based mental health settings do. School-based services have been shown to effectively decrease mental health problems in children, emphasizing the important role that school personnel have in supporting children's well-being. And in addition, many school professionals, including school psychologists and counselors, have specialized training to address student mental health concerns. Today, children and adolescents are more likely to receive necessary mental health care in their school than in any other setting. And of children and adolescents who receive mental health services, 70 to 80% of them receive them in school. So a public health approach to school mental health recognizes the importance of the environment in which children live, learn, and play. I'm showing Bronfenbrenner's ecological systems model to depict how environment has a crucial impact on an individual's development, particularly the more direct effect of the microsystem. And while interventions solely aimed at individual behavior change are important, they are usually not enough. So as such, interpersonal, environmental, and social changes must be made to sustain improvements over time. So for my methods, I'm presenting a flow diagram of my screening process, and my initial search of school-based and mental health on PubMed generated 2,596 results. And after filtering for only clinical trials within the past 5 years, 2,488 records were excluded. The subsequent 108 records were then reviewed with the following exclusion criteria of not being a school-based intervention, a completed study within the US, or focused on mental health, leaving a final of 14 articles for this review. So the 14 articles covered a broad range of interventions with 11 unique interventions tested. And due to this large assortment, it would be difficult to go into depth for each intervention. So they are categorized on the left side of the table, which include yoga and mindfulness, implicit bias among school clinicians, emotional and behavioral health crisis, mental health stigma, sluggish cognitive tempo symptoms, which includes symptoms of slowness, mental confusion, excessive daydreaming, apathy, and drowsiness/sleepiness, and it's often comorbid with ADHD, depression literacy or prevention, suicide risk, and anxiety treatment. So for key findings, the yoga ed curriculum was found to decrease anxiety and depression symptoms, but these findings were not statistically significant. The study does, however, provide new evidence for utilizing yoga and mindfulness practices with middle school students, where previous studies have focused on elementary or high school students. It also adds to the sparse literature from urban settings on school-based yoga for youth, indicating its potential for feasibility and effectiveness. The virtual implicit bias reduction and neutralization training was rated to be highly appropriate, acceptable, and feasible for school mental health clinicians, with the mean implicit bias knowledge quiz scores of participants significantly improving from pre to post training. Participants retained their implicit bias knowledge gains as their follow-up quiz scores at 14 and 24 weeks remained high. The beliefs and attitudes for successful implementation in schools training was found to have a significant impact on proximal mechanisms of behavior change, such as attitudes, descriptive social norms, and self-efficacy, but additional work is needed to confirm these findings. And the emotional and behavioral health crisis response and prevention intervention had a significant positive effect on school safety while minimizing the use of disciplinary responses. This resulted in less office discipline referrals, bullying reports, and suspensions. Exposure to the curriculum intervention, eliminating the stigma of differences, was associated with a significant increase in knowledge and attitudes and a significant decrease in social distance from youth with mental illness. Sluggish cognitive tempo symptoms decreased by almost 1 symptom and at a significant rate in the skills-based and goal-based intervention groups compared to a waitlist control group. The Adolescent Depression Awareness Program had positive effects on depression knowledge, treatment-seeking behavior, and stigma scores. This shows the potential for ADAP to improve outcomes associated with untreated depression, including a reduction in the risk for suicide through greater treatment seeking. The high school transition program was found to be effective in reducing depressive symptoms and anxiety scores through improving school attachment, while also preventing the onset of depression in some youth. The PHQ-9 increased identification and treatment initiation for adolescents at risk for suicide, which confirms the value of universal screening. And modular cognitive behavioral therapy was superior to the treatment as usual group at post-treatment for anxiety. However, youth in both groups showed similar levels of clinical and functional improvements. This points to the effectiveness and priority of providing any type of treatment for youth with anxiety. So keys to successful implementation were also reviewed, and one article highlighted 3 challenges, including high staff turnover, insufficient buy-in and support, and insufficient time for training and planning. And some strategies for improvement and to overcome these challenges include school and district leadership trainings to improve the school climate, workforce incentives, building motivation for innovation and leadership trainings, and encouraging active innovation involvement. Building buy-in with school and district leadership, and developing a strong memorandum of understanding to establish accountability and expectations for training participation. There was also an emphasis on developing adaptive implementation strategies in which the specific strategy is chosen for a school based on their level of readiness to implement an intervention. So I know that was a lot, but to summarize the big ideas, children's mental health crisis is an urgent public health issue that needs to be addressed, especially in schools. And interventions must rely on evidence-based practices, as they have been shown to be effective in improving outcomes. More research is needed to increase the generalizability of findings, particularly across age groups and different settings. Emphasis should be put on sustainability for future work, which includes assessments of long-term outcomes. And it's important to utilize successful implementation strategies when implementing evidence-based interventions to increase the effectiveness of interventions and sustain them over time. So next, I would like to move on to acknowledgements, and I acknowledge my primary reader and academic advisor, Dr. Mary Catherine Augustine, for all her help and guidance throughout the last 2 years, and particularly with my thesis. I'd next like to thank my field placement preceptor at SAMHSA, Dr. Sunny Patel, who introduced me to this area of children and adolescent mental health and really expanded my professional interest to public mental health. And lastly, to my family and friends for all of their support and endless encouragement throughout my life, but especially in the past few years. So here I provided some mental health resources for young people if anyone's interested, and this includes national helplines, toolkits, and a directory to find treatment. Then here are my references, and that's it. So thank you so much for listening, and I'd like to take any questions now.
Jacqueline, that was fantastic. Taking on a systematic review is no small feat, so congratulations on completing this project. Are there any questions for Jacqueline? This is certainly a hot topic right now. Of the interventions that you read about, and you may not have the number off the top of your head, but were many universal versus kind of targeted to high-risk students? Were you able to tease that out at all?
I would say a few of them mentioned that, and I think most were universal. Yeah, so 5 of them were universal, 1 was targeted, and 3 were indicated.
Okay, good. Yeah, I know that was an issue following the pandemic, is identifying evidence-based programs that were more universal for students. So that's great. Allison has a question for you.
Yeah, I'm just piggybacking off what you said, Erin, about systematic reviews being a large feat. I'm wondering, I mean, very impressive that you were able to review all of those articles. Do you have any advice for people that are considering doing systematic reviews in the future? Any lessons learned?
Yes, I would definitely try to narrow my topic more. I actually did want to have a more focused topic, maybe just like a certain intervention or like certain intervention aims, but there was very limited literature on just, a few interventions. So I did have to broaden my topic a little more. But if possible, I would say to try to narrow your focus as much as possible.
Great advice. Systematic reviews are definitely challenging. I really appreciated your slide on the implementation success, like keys to successful implementation. I just wanted to note that many of them are true for multiple different school-based interventions. Having that, school level buy-in is really important. Were any of the implementation success factors, do you feel like any were really specific to mental health, or do you think most of them were more global?
Yeah, I do think most of them were pretty global. I don't know many school-based interventions, to be honest, but I do think so the challenge of high staff turnover might be a little more particular to school-based mental health clinicians, and maybe they get burnt out more. So just building staff capacity and like having retrainings might be more important to them.
A great point. You should put that in your discussion. That was a really good point. So, are you planning to submit this for publication?
Not at the moment.
Oh, you should definitely, all this work, we should definitely.
So say all that work, yeah.
I'll consider it. Thank you.
Yeah, if you need department support, I'm sure lots of faculty members would be happy to help. Any other questions for Jacqueline? All right, again, if you think of one, we'll have a little bit of time at the end to loop back around. Very nice job. And so now we have our last presentation is also a review. So we get to hear about a different approach called a scoping review, which we're excited to see. And this presentation is from Mon Han, who has a Bachelor of Medicine and a Bachelor of Surgery in Medicine from the University of Medicine in Myanmar. And she has a Master's of Science in Public Health from the Institute of Tropical Medicine. And she's in our women's sexual and reproductive health area of interest. And her master's essay is a scoping review entitled Violence Against Women and Girls, Response, Interventions, in Conflict Settings. So feel free to share your screen.
Thank you. Let me share my screen. Can you all see the screen? Okay. Hi again. I'm Mon Han. I will be talking about my master essay on scoping review about violence against women and girls, response intervention in conflict. Wait, it's not moving. Okay, so I just want to share first how I have come to work on this topic. So these are some of my photos from walking back home in conflict area. I was working on integrating the violence against women and girl response intervention in healthcare setting in the conflict area. And the last photo was I was trying to, talk about family planning, counseling, and knowledge with the community. And then when I reached to the topic of domestic violence and discuss a little bit about marital rape, I still remember that the one man from the group told me that it is the responsibility of the woman to take care of, household chores and even to fulfill their sexual needs. And at the same time, the women in the group were like so angry and so furious. And that moment makes me realize that all those things I was just reading from the books and the papers are really happening in the real world, and it's important to work on this issue. That's how I reached to work on this area of work. So just to set the ground about I prepared some definitions. So violence against women and girls, it's a form of gender-based violence that is targeted towards women and girls that can result in physical, sexual, and mental suffering. And it can occur in either public or in private life. And to give the context of conflict globally and also region-wide, the UN OCHA office estimated that in 2024, 300 million people are in need of humanitarian assistance and protection. And it was estimated that in 2022 data showing that almost 71 million people are internally displaced due to conflict. And this map is showing the top 10 countries globally with the highest number of IDP. And we can see that the majority are in African countries and a few other also in Southeast Asia from where I am. And in the conflict zone and violence against women and girls, we have to talk about conflict-related sexual violence. So it's different forms of sexual violence that is against women and girls, but this definition also include for men and boys that can either be directly or indirectly linked to a conflict. So in case of CRSB, the perpetrators can also be, the armed forces, the government officials, and also in conflict setting, there are also non-state armed group, and even, humanitarian worker like us and UN peacekeeper. And for the prevalence of CRSV and conflict, the data showed that 1 in 5 women, either refugee or displaced women, are facing sexual violence in humanitarian setting. And during Rohingya crisis back home in Myanmar, the Myanmar military perpetrated sexual violence against Rohingya women and girls. Also, I also want to talk about another form of violence against women and girls in conflict. So this is intimate partner violence. It's a behavior within intimate relationship that can be either in physical, sexual, or psychological, even in economical form, that it's perpetrated by either current or former spouses or partners. So why IPV in conflict? So in conflict setting, the WHO data estimates show that the country with higher IPV prevalence around the world, majority of them are also affected by armed conflict at the same time. And also study from Eastern DRC, Northern Uganda show that 80% of women in conflict area are facing IPV. And even in both conflict setting like Liberia, 50% of women are at the higher risk of IPV. So looking at the consequences of CRSV and IPV, first, it's affect the mental health situation of the survivor. That can include post-traumatic stress disorder, depression, and even suicide. And the survivor are also facing stigma and exclusion by the family and the community. Looking at the health perspective, we can also see the injury from physical health consequences and, of course, sexual and reproductive health consequences, such as, unwanted pregnancy and induced abortion and other sexually transmitted infection too. So based on this background, I did the scoping review with the objective of to learn about the current knowledge on response intervention and also to highlight key areas for future intervention approaches. I used this multi-sectoral approach framework from UNFPA that cover the survivor needs in humanitarian setting for violence against women and girl survivor. So looking at in the middle is survivor, including community under the protection because it's an emergency situation, and the services can be health, psychosocial support, including livelihood initiative, also safety and security for the survivor, and legal and justice services for the survivor. I will be presenting the result of the scoping review according to this framework. So I did a scoping review with these 3 concepts, violence against women and girls, and from conflict affected population and conflict setting, and looking particularly at the response intervention. The table is showing the inclusion and exclusion criteria that I used during my review process. And the result of the review show that just like my friend just now, I also included 14 articles in the final stage. And this is the Prisma flow chart showing the whole review process. I also look into the Grail literature documents because in this setting, most of the interventions are done by UN organization and INGOs. This is the map showing the location of the study from these 14 articles. Again, we can see the majority are in the African countries, and the most study are from the DRC Congo, followed by South Sudan and Syria from the Middle East. We also have some study from Southeast Asia, but due to the Gray literature document, it's mostly due for the setting in the natural disaster, not directly conflict. So first, I want to talk about the mental health and psychosocial support intervention that's coming out from the review. And the intervention that has been evaluated in this study are cognitive processing therapy, a type of psychological support for adult women survivor, and cognitive behavioral therapy for adolescent girls. The study also look at the CBT and effect on social capital and also the effect on stigma that the survivors are facing. And one study also look at mobile approach or GBB service delivery in the conflict setting. Another results show the economic and livelihood intervention. And the intervention look at, in the village, because most of the intervention are working in the host community in the conflict. The village saving loan program plus gender dialogue group. And they also look at the solidarity group, which is like community-based economic and psychological support combined intervention. And our one Gray literature document look at the cash assistant integrated GBB case management in conflict setting. And for the healthcare, most intervention are just looking at the training programs, and when specific intervention look at the comic book approach to provide services for the adolescent sexual violence survivor. And one interesting study was looking at the GBB screening to integration at the primary healthcare clinics in the conflict setting. And we also identifying the women and girls safe spaces intervention in the conflict setting. This is from the Gray literature review, where they look at whether participating in the women and girls safe spaces has the following effect on the survivor, such as their knowledge on service, knowledge and utilization, and having social capital such as quality female friendship from participating in the safe spaces, and also the effect on their mental health and on their knowledge on the gender equitable attitudes. The last result was from legal and justice intervention. The review can only identify one Gray literature document that is looking at the best practices for legal and justice approaches, but it is a mixed context, both conflict and the natural disaster setting. So here, I just want to highlight that the best practices include the mobile GBV legal services into the villages or into the, the urban informal settlement setting. And also they talk about local women organization empowerment in this kind of crisis setting. And also the legal system, we also need to look at the importance of the local customary and informal justice system in the case of crisis setting. So to conclude, the review highlight that the intervention from psychosocial support and livelihood initiative are quite strong, given their strong methodological evidence. We still need to continue doing research on the other three sectors, such as safety and security, legal and justice sector, and also healthcare services provision in conflict setting for survivors of violent survivor of women and girls. And a few limitations that I identified from my review is that we can also see from the map that most of the studies are in African setting, especially from DRC. There are some other countries that are facing conflict globally too, so we can do research in other country. And due to the challenges of the context, like active conflict and people moving from location to location, it was a challenge for the intervention to do follow-up later after the completion of an intervention. And just like I already mentioned, there are very limited study from healthcare intervention and only gray literature study on women and girls safe spaces and legal services. That's the end of my presentation. I would like to thank my reader, Kate, for her kind support of PFRH family, my family and friends who are also near and far, and colleagues back in Myanmar. These photos are showing the buildings are the healthcare facility in conflict zone in Myanmar. And I just want to put this meal table because that's what the best they can offer in such kind of setting. You can all see that those are all vegetables. Thank you. Any question?
Wonderful job, E. That was another just enormous undertaking and just so impressive that you were able to do all that. I really appreciated your framework and kind of how you presented the findings in line with that framework. It was really nicely done.
Thank you.
Do folks have some questions for E? I just wanted to ask a little bit about your gray literature search. I always appreciate when people do that because you know, not everything gets published, and just to kind of dig into other sources of especially interventions and things like that. Could you talk about what you found? Were they reports? Were they governmental reports? Kind of talk a little bit more about how you did it and where they came from exactly.
Sure. Initially I found some gray literature references in the paper that I was reading, and because I've worked in this scope of work for like almost 5 years back home, and I know the name of the organization that are working on this specific issue in conflict too. So I just did actually a Google search on the term and Google Scholar, but most are from like, you know, like kind of like snowball sampling from the article that you're reading and then the organization referring. So I found the one document from CARE International, the GVB case, sorry, cash assistant integration for GVB case management that they are doing in, I believe it was in Iraq. And the legal and justice services was the really, really difficult one to find. It was from IDLO, I believe it's International Development on Legal Organization. Yeah.
Thank you. Yeah, that and that's the joy of the scoping review, right? You can have kind of a little, not, I don't want to say loose because it's clearly very scientific in your approach, but you can include additional articles to kind of round out the qualitative aspects of the work that you're reviewing. So yeah, I'm a big fan of a scoping review. I think it's a really great contribution. Are you going to publish this as well?
Yeah,
Good. All right. And we're gonna get Jacqueline in there publishing hers as well.
I will.
And we didn't ask Mita that question of her data analysis, so we'll have to see. Are you planning to publish yours, Mita?
Yeah, maybe. Yeah, I've been thinking about it. So
All this work, you know, get it out there so that when
Yeah.
people review things later, they can cite it, so it can be included. Are there other questions for E in her presentation before we open it up to the whole group? It's definitely a quiet group today. Okay, so if you want to take your slides down, I just want to step back and just, you know, open it up to anyone who has any questions, or speakers if you have questions for each other. We heard 3 wonderful talks today. Really great science was shown today, some really nice analyses, systematic review, scoping review. I mean, this is really, really impressive and really says a lot about you all and the effort that you put into your program and having a great product. So with that, any final questions for any of our students? Everyone's being very quiet. We could finish early and give you 15 minutes back in your day. Maybe could you each maybe say a little bit about your plans following graduation? If you have them yet, you may still be waiting to hear, but anyone have anything specifically planned following graduation? Everybody's waiting.
I mean, I still need to finish other assignments, so.
And Mita?
Yeah, I was gonna say I still have 2 more finals. But I actually am applying to medical school this cycle. So
Okay, well, good
fingers
luck with
crossed
that.
it goes well. Thank
Yeah,
you.
fingers crossed. That's wonderful. Well, we are so proud of all of you. You did a great job today. Good luck with your finals, and we're excited to see everyone at graduation. Thank you all for coming and joining us today, this afternoon. And again, congratulations on really great products. So great job today, everyone.